this is last case.
Yeah.
This is more complex superficial femoral artery. This is a 75-year-old male, history of PAD, has a known left external iliac artery and common iliac artery occlusion. He came in with the right leg problem. Sorry, at that time they did a fem bypass to, for his left leg claudication. That was done 10 years ago. 4 years ago, that bypass failed, so he required another surgery. So you know that the right groin is a really hostile groin. The left groin, you can't exit for the right side anyway. He started having claudication on the right side 6 months ago. We did an ABI. You see on the right side, ABI is 0.4, or ABI on the left is 0.92. The CTA confirmed the occlusion of the left common iliac and external iliac artery that we know about, but now there's an occlusion of what they call it an ostial SFA versus distal common femoral. And so the question is what options we have in this patient. He can go from the contralateral. Pedal will prevent you from having imaging. So we decided to go radial on this patient. And this is the picture. You can see our selective microcatheter. And, fem bypass is open, but right after that, you guys see a severe 100% occlusion. That
Hmm.
was, my
Yeah, it's
fellow.
tricky.
Yeah, that's tricky. So, we give our fellows all the opportunity to wire complex lesion. So, because that's the only way they learn. And that actually was her second month in our endovascular fellowship. And we chose to go with a Surmatic long sheet, 120. We used a 150 supporting catheter, and she was able to cross it using a Command O1H wire with a lot of skills. And I think she did a phenomenal work. And the wire behaved like there was a micro channel that she was able to find, and she crossed it. But we couldn't cross the microcatheter. That's how tight it was. So we used a 2.0 balloon that just to get a channel. We advanced the microcatheter through. We swiped with the 475 Viper wire, and we did a orbital atherectomy. The trick with the orbital atherectomy is we make sure that we do not cross where the fem bypass take off, because we do not want to damage that, because that will make our case an emergency if that fem fail. Of course, as I said, we always do IVUS in those situations, and we had to do more orbital atherectomy after the IVUS. We end up ballooning with a 740 short balloon after atherectomy, then a drug coating balloon. And we use a 6x100. I'm not sure why we use a 6x100, not 7, but I think maybe we didn't have it at that time. And at the end, I'll show you the final result. We did a pullback after the final result. Again, this is the initial result. Basically, you can't see good vessel there. You can't even see the profunda. And this is final result. So the grading was 5 millimeter mercury afterward.
Fantastic. Yeah.
So, this is just different examples. Again, I'm not advocating for someone to do a very complex case from the get-go, but if you're going to be a true radialist, I think that's the type of cases you can end up tackling eventually.
Yeah.
And we love those. If I have a couple of minutes, I want to show you something here. Our hospital has been doing this for almost 4 years. We've been collecting data. We've done close to 400 radial case. We've published multiple times in ACC and TCT and other society and conferences. And our last publication that we published recently in last TCT in San Francisco, and basically we looked at iliac lesion that we tackled via radial access and compared them as propensity match to femoral access of the same type of lesions. So we had 138 patients, and this is a busy slide, but basically it was a retrospective. We looked at it from February 2020 to September 2022. And of course, all diagnostic cases were excluded. And we pulled all the data. If you see here, there's really no significant difference between the patient populations. They were very close to each other in terms of demographic features. And what the results showed that, of course, what we expected, the length of stay were shorter in the patient who underwent a transradial approach. There was no difference in procedure time. There was no difference in the volume of contrast. 3 cases we had to convert to transfemoral, either because of arterial spasm or requiring an alternative access kind of to cross and snare and, a pre-crossing device. And if you look at the difference, really in hospital, this is actually not supposed to be in hospital. Stroke was one case in the radial versus 0 in the femoral. They said it was actually 28 days after. Access site hematoma were similar. 30 days mortality was similar. But then you look at 1 year mortality, there was a higher mortality in the femoral access. Again, there was a trend to higher mortality. The question is that just because the complexity of the patient, or I don't have a good reason why the femoral access patient had a higher 1 year mortality. So as a conclusion from our trial, we think it's, the transradial approach is a viable, safe, and non-inferior alternative to transfemoral in treating patients with iliac disease. And as you mentioned before, it's all about patient selection and, having more and more experience with those cases.
Sam, thank you so much for sharing. That was fantastic. Appreciate it. Thanks for
Definitely.
coming on the show. And hopefully this isn't the last. It's clearly got a lot of knowledge to share. So hopefully we can bring you back on to talk through some more cases.
Well, thank you so much for having me on the show. And again, it's we call it the radial movement. So hopefully we can be taking the first steps and help others to adopt it and uh, improve the technology we have.
Well, especially as the industry advances, which, as you mentioned, we're going to be see some new stuff down the pipeline. So we could probably even have this same conversation 2 years from now, and it's completely different.
One of the goals we have um, is to look at the financial impact on our patients. I think that's extremely important. And we've had data from the radial to coronary. Dr. Amin has done nice work publishing that over 2017, 18, I think 2021, if I'm not mistaken, from the radial to coronary world. And hopefully we can have enough volume in the radial to peripheral in the next couple of years that we can pull similar data and show the financial impact on our patient and our healthcare system, and maybe the length of stay and same day discharge, which can push the needle to have more people adopting this technology.
Yeah. Well, thank you so much.